Welcome to Evening Rounds, a podcast that takes you behind the scenes in medicine. Tonight, we're chatting with Dr. Jeffrey Rosenfeld, a neurologist who believes that the most debilitating condition is fear, and that the only cure for fear is hope. If you like what you hear tonight, please subscribe. Jeff, thank you for being on our Evening Rounds podcast today. Been wanting to have you on for some time, and I'm glad our schedules work to make it happen.
Absolutely. Thank you very much for the invitation. I'm happy to be here.
You are the director of restorative neurology here at Loma Linda University Health, and we're going to unpack that a little bit. In our conversations before, you've talked about the importance of hope. And we often think about hope as an antidote to fear. Fear can encapsulate many of our thoughts, particularly when we can't control what is happening to us.
Right.
I'd like to hear some of your perspectives on that as it pertains to how you take care of patients, but also how you apply it in your own life.
Right. You know, for all of my training and all of my time as a neurologist since training, one of the messages or lessons that have been so powerful for me is that regardless of the disease, the one thing that most of our patients walk in the door with is fear. Mm-hmm. Because unlike so many other areas of medicine, oftentimes neurologic disease takes you out. You didn't see it coming, or you're unsuspecting. You didn't do anything in terms of lifestyle choices to bring that on. So the uncertainty of it, the unpredictability of it, leads to fear. And it's been my impression, as you just mentioned, that of all of the disabilities that our patients experience, whether it's difficulty breathing or walking or moving or thinking, fear is the worst. Fear is the worst disability. Because it affects your judgment. It affects the way you handle anything else that comes down the way with respect to the disease. So the only way that I have ever found to address fear is hope. And how you offer the hope is the art of treating the patient. But you have to offer the hope, because if you don't offer the hope, the rest are Band-Aids. And those Band-Aids sometimes are not enough for a disease that keeps dishing out more fear.
Mm-hmm. The diseases that you take care of, can you talk a little bit about what kind of neurologic diseases those are?
Absolutely. So my area of neurology is called neuromuscular medicine, and that's quite a few diagnoses. There's 70 to 100 different diagnoses under that umbrella of neuromuscular. Generally speaking, they're diseases of the spine, the nerves, the muscles, the connections between the nerves and the muscles, sometimes the brain, in that it affects the spine and the nerves and the muscles. So disorders like ALS, amyotrophic lateral sclerosis, muscular dystrophy, myasthenia gravis, many inherited genetic forms of nerve, spine, or muscle disease. So the manifestations of those diseases are very different, but the consequences are similar. They generally affect the way a person can get around, or they affect the way a person can function in their regular day. And for the most part, as I mentioned earlier, the person did nothing to bring that disease on.
Yeah. With something like ALS, I feel like, you know, we hear about ALS, and a lot of us maybe even have loved ones or friends or family with ALS. And it seems, I mean, any progressive disease seems so inhumane and so cruel. My son doesn't have ALS, but he does have a progressive disease. And I just remember thinking, to take away a person piece by piece, you know, when you're faced with that patient coming in with that new diagnosis, how are you possibly offering hope in that situation?
Yeah, I get that question a lot, actually. And, you know, I remember when I was in training as a neurologist, and I didn't know what I was going to do, and I didn't know if it was going to be neuromuscular or any of the other areas of neurology. But I do recall the notion as a young resident that while I didn't know what I was going to do, I knew I wasn't going to take care of ALS patients.
Really?
Because of exactly what you said. And then I did. I did take care of some ALS patients. As a resident, I was familiar with some, and then as a young faculty member, many others, and got involved in some clinical trials. And what I found was the payback is the wrong word, but what I got back from the efforts that I put out was so incredible. It was like 100 to 1 in terms of what I got back. And why was that? Because if you change the course of a disease, you make the disease more livable. You make that person understand what they have more and not be afraid. The magnitude of that impact is so much greater than just telling a person, we've got you.
How do you make them not afraid?
Well, that has to do with the Center for Restorative Neurology and that model of care that I came to Loma Linda to build. The model of care is that a person who comes to see me, regardless of what limitations or problems they have, they're going to meet my whole team. They're going to meet physical therapy, occupational therapy, nutritional therapy, speech and language pathology, dietary and counseling. Even if they don't have a problem in that area, I want them to walk into that room and see all the stuff that those people have on the walls and on the counters. And I want them to say, I don't know if I need any of that, but I'm glad somebody's here. And then when you do that 7 times every time they come to see me, the takeaway message is somebody's got my back no matter what happens here. And I don't have to be afraid because they got me. And you see them frequently enough so that you can keep checking in. And the second piece to addressing the fear is to be proactive. Don't wait for the problem. Anticipate when somebody might have trouble swallowing. Anticipate when somebody might have trouble breathing and intervene before the problem as best we can. And when you do that repeatedly enough, hopefully, that makes an impact. So you can be hopeful at any stage of disease progression.
So how did you come to that point? That to me,
You mean to Loma Linda, how did I?
yeah. So first,
What is it?
you have this amazing clinic structure that fits and dovetails so nicely with what we are about here at Loma
Right.
Linda. So how did that marriage happen?
Well, I've been very fortunate to have built a similar program several times in my career. This is the 3rd time. And when it was time, when I was looking for a new opportunity, I was in California, in Central California, and I was looking for a new opportunity, and I didn't know that about Loma Linda. I knew from a colleague that they might need some help, and I called down and I said, I'm interested. And they said, come down. I did. And I came down specifically to talk about what I wanted to do. And 2 important things happened on that initial visit. One is I walked in and I saw that sign that's in the Coleman building, that big emblem that says to make man whole. And I thought, wow, they got it on the sign.
Yeah.
I've never had it on the sign before. When the other places have done this is going to be easier. And the second thing that impressed me is when I laid out what I wanted to do in that initial visit, they didn't say yes right away. They said, we like that idea, but we can't promise that. But we will promise you that you'll have a seat at the table to tell that story. And then we'll hopefully put it together with you. And I thought that is so realistic, because if they would have promised the moon, then I would have been more skeptical. But they didn't. They said, we will promise you the opportunity to tell that story. And that's what happened. So I came here and I put the pieces together, and the hospital was very generous. They gave me a business manager from within to help me come up with the financial aspects. And I got invited early on to a HELM meeting, and you know what that stands for, and I don't. But
Hospital Executive Leadership.
Okay. So
Meeting.
I was invited to this HELM meeting, and I knew that I had to make the case at this HELM meeting. And so I really did my homework. I didn't know anything about the HELM meeting. I didn't know, I was early on here, I didn't know most of the people there. But I went there along with this business person, and I was prepared. I was prepared to tell the story, because I had a lot riding on this. I had already decided to come here, and I knew that this group had to buy in the sense, because the program involved resources from the hospital as well as resources from FMG. And I told the story in an abbreviated form, and then I was waiting to see how it was received. And one of the administrators at that table said to another administrator, wasn't talking to me, he's telling us our story.
Oh, that's so cool.
And I thought, I didn't see that coming. And so I watched. And then they talked amongst themselves. I didn't say a lot more. I mean, there was a few questions, but for the most part, they spoke amongst themselves. And then at the end, when it got back to me again, they said, what do you want? What would it take to build it here? And that's what happened.
That's incredible. I feel like you, over the years, no matter what you're doing, you're kind of putting those puzzle pieces together and
That's
making those connections happen.
I think that's true. This is a unique program. It's unique because, in many respects, it's a collaboration between the resources of FMG and the resources of the hospital. It's unique because we have embedded within the center all of these multiple disciplines.
Yeah, especially those with, mobility is an issue, right? And so being able to have it all there in the same area and be able to just give them that comfort of not having to go to multiple clinics.
That's the irony when I say that this is a unique program. It really shouldn't be.
Yeah.
Because the one thing that's so common among otherwise very different neurologic diseases is that they affect your ability to get around and to move oftentimes. And so the irony is the one thing that the patients have the hardest time to do, we often ask them to do the most, which is to come back and forth and back and forth. Come for this therapy, come for that therapy. And then they're not in the same spot on campus often. So putting it all under one roof at one time and focus their attentions, it's even more impactful.
Yeah. No, 100%. That makes a lot of sense. Let's play on words a little bit. So we've talked about restorative neurology. So how does Jeffrey restore himself?
Yeah. Some months better than others. But I would say that there's a couple of things that I love to do. I love woodworking, and particularly wood turning. So I don't know if you're familiar with that, but wood turning is when the wood is on a lathe and it's spinning and you're making things out of it. So you can make a bowl, or you can make things that are round, usually a bowl or a pen or a vase, bowls, pens. I've made a lot of things. So wood turning. And I love wood turning for many reasons, because you often don't know what it's going to look like when you're done, when you start. So the wood is spinning, and then I carve down into the wood, and the wood chips are flying everywhere, and I don't know what it's going to look like, but you carve down to the shape I see as it's evolving. So that's very relaxing to me. I really can reflect a lot. Gardening, I love to garden. I have, when it's the season, I just love the simplicity of gardening and the final result of gardening, and I try to improve on the garden. It's not a huge garden, but it's very meaningful to me.
Is it in boxes, or is it in the soil? Or
It's in boxes above the ground. I also like to bake, and particularly I like to bake bread. I bake bread every week. And that's because I eat bread every week, and I eat the bread that I make. So it's kind of self-serving, but I really enjoy that. I like the process, even though it's so simple, and it's not a mystery about how it's going to come out, because I make the same bread.
That's spoken from someone who can make bread well, because to me it is a very complex and actually mysterious process.
There is too much chemistry from my brain in that process.
So when you say simplistic, talk to us a little bit about that.
Well, sourdough bread is what I like to make.
Okay.
So sourdough bread is 3 ingredients. It's flour, it's water, and it's salt.
It's also patience.
Yeah, but the bread does all the work.
I love
all you
that.
have to do is pay attention a little bit. But I would say I make at least 2 loaves of bread a week, and if it takes 20 minutes total over the time of making it, it's a lot.
I think you're at master bread making status if that's where you're at.
If that's the case, I'll help you after
Yes,
the
I need
podcast. I'll help you with the tutorial. It's really not that difficult. Yeah.
So you do it you do it in one day, or how do you do it?
No, it takes 2 to 3 days, depending upon how active the starter is. But it's not. It's mostly sitting on the counter. It's mostly. So I guess if you count the waiting, it takes 3 days to make it. But I'm doing other things.
So as a child, were you set on medicine from early age, or what's that journey been?
No, I don't know that I was. I might have thought about it periodically, but no, I don't recall wanting to do that. I had different fantasy careers as a child, but when I went to college, I had the good fortune as an undergraduate to get involved in some research projects. So when it got time to decide what I wanted to do for after college, I was thinking about medicine at that point, and my undergraduate advisor from that lab said, don't do that. Don't go to medicine. You're not going to like it. And I said, why? He said, you ask too many questions. I very well remember that conversation.
Really?
I would think that would be a perfect candidate.
No, actually, I'll tell you why. So he said, go to graduate school.
Okay.
Because graduate school will teach you how to think. Graduate school teaches you how to put ideas together. So I did. I went to graduate school. I got a PhD in neuroanatomy, and I was a researcher for a while. I did a postdoctoral fellowship at Johns Hopkins. Then I took a junior faculty position there. And then I had sort of an epiphany, and I thought all of the projects that interested me most in the research world, they were clinically relevant projects. I would gravitate towards what we now call translational research. It wasn't called that then, but now call it, which is applicable to the clinic. And I was using clinical materials, and I thought, my whole career, I'm going to either be beholden to or working for a physician that has access to that. So I like the dynamic. I like the people. So I went to medical school after my postdoctoral fellowship and my junior faculty position. And it wasn't until after that that I was able to put it back together and combine a research experience with clinical experience.
I'm fascinated by that, but I want to go back to your advisor, your undergrad advisor, and when he said you asked too many questions, and you went down the PhD postdoc pathway, and then he came back to medical school. When you reflect on that statement, what do you think he or she was meaning by that comment, and how did that impact you? Because in a positive way.
Mm-hmm.
Well, I think he was probably right at the time. And what he meant was that I challenged things. If it didn't make sense to me, I didn't usually just accept it. Yeah. I would ask questions about it. I would go further. And I was probably, as a young trainee, I was probably annoying to have around because I would challenge these things, And going to graduate school, separate and apart from medical school, because nowadays many folks combine them, they are very different training experiences. Graduate school is a professional school in that it's not about the content that you're learning. It's about the process, about the process of putting ideas together, to be critical, to be reflective. It's the scientific process. Medical school, especially in the beginning, is a vocational school, and it's all about remembering. Don't keep asking me why. Just remember that this is the differential for this, and this is the list. So as you're aware, you spend a good part of 2 to 3 years memorizing lists.
So you wore many hats before you found your way to us here at Loma Linda, and you and I share a similarity where we were both EMTs a very long time ago. Yeah. And I loved how I think I've heard you say it taught you a lot about remaining calm. Tell us a little bit about your experience as a volunteer EMT firefighter.
So when I was in graduate school, I lived in a small New England town. It was an idyllic town. It was great. And the kind of town where if you wanted your mail, you walked into the post office and they handed it to you. I didn't even know the combination to my box. There was no mailbox.
Wow.
And I happened to live next door to the fire department. And it was, of course, a volunteer fire department. And when they needed to summon the volunteers, there was this siren, a very loud siren. And when it would go off, because of the proximity of my house to that siren, my house would vibrate. And so whatever I was doing, I wasn't doing it at that moment. And so one day, in exasperation, I said, I'm going to go down there. I'm going to see what's going on. And I did, and I liked it. It was like a camaraderie of guys that were volunteers, and they had very different backgrounds than mine. I was a graduate student at the university in the next town over. They were often of different backgrounds, and they encouraged me to take the EMT training course, which I did. And in this little town, we had a highway, interstate highway that passed through part of it. And so anytime there was a car accident on that highway, they would call us. And so there were two good things about that. It was an interesting experience. I didn't have a desire before that to be a fireman or an EMT. I got a lot of interesting experiences doing that. But the other fun thing is because I lived so close to the firehouse, I was often there first.
Yeah.
And if you're there first, you can drive.
Nice.
So I got to drive the fire truck and or the ambulance. And if I was there second, I would jump on the fire truck or the ambulance and we would go. So it was very fun. For about 2 or so years, I had the opportunity to see different scenarios. And to your point, when you come on the scene of an accident, for example, you're seeing people having perhaps the worst day of their life so far.
Yeah.
And so when you can add a stability and structure to that and a little reassurance, that left an impression with me. I mean, I couldn't make their situation better. I couldn't necessarily take away the pain. Our goal was to stabilize them and get them to a hospital. But I could give them the confidence to say, relax, we got this, we're getting to the next step. And that structure was impactful to me at that time in my life.
I always think it's so amazing to be able to be that first person there, to be able to be that presence for them. And I think it's, you learn a lot about how this is not my emergency. So I need to be the calm one.
Yeah, that's right.
And I need to be the measured one.
Yeah. So I suppose on a different scale, we've extrapolated that to a clinic practice.
Right.
Yeah.
Exactly.
Yeah, there's a lot of similarities there.
I guess. I guess that's true.
What are some guiding principles that you use when you approach a patient and their family and the disease that they come with?
Well, at the Center for Restorative Neurology, or CRN, we call it, there are 2 big areas, I call them guiding principles. The first is I want the patient to understand, and the family, that there is a hopeful alternative at every stage of disease progression, that we are not going to say we're done. And I want them to know that proactive is better than reactive. The second guiding principle is usually relevant when they first come, and that is that the stress of getting the care should never be worse than the stress of having the disease. And it is.
Sad.
There are many shortcomings to our healthcare system. And first and foremost is the point of care. When patients come for what they think we might have to offer, but their insurance company says no. So I address that. Fortunately, I've been able to attract enough grant support from foundations, from grateful patients, a variety of sources, so that if someone wants the care but can't get the care, we'll pay for it. We'll cover. Now, I understand what you might be thinking. It's not a great business model to pay yourself. We don't do it on every patient every day. But I don't want somebody not to get the care because an insurance company said no. So we have these resources, and I'll use them to get them in the door. And then we help them, guide them towards perhaps different coverage that might cover them for the long haul.
When I first met you many, many, many years ago, we were working together on a patient media segment, and we were profiling a patient. And what struck me about this ALS patient was how he was, I believe at the time, my age. And he was a photographer, and it was so heartbreaking for me. And I'm just so astounded by your just hope that you have and the hope that you're able to give these patients. And it's really astounding when you think about what they've read on the internet or what they've heard from friends or family. And it's so inspiring to me that you continually never lose that hope.
Yeah, well, thank you. We try. As a point of interest, that patient is still alive, and he taught me a few things, that patient, because he himself was extremely resourceful. And you might remember that he was a photographer, and he didn't have use of his arms any longer. And he showed me pictures of me in clinic talking to him. He was quite good. I don't quite get how he knew how to put a person in the frame, but he was good. And so that was a great example, that patient, of ways to accommodate your passion with your disability.
Yeah, it's incredible.
Love that. I liked what you mentioned about learning from your patients, how resourceful they are, and when they face challenges, unexpected or expected. The wisdom that you provide your patients, have you ever had to reflect on your own comments that you've made to patients and apply it to your life?
That's a very compelling question. And I would say yes. I mean, thankfully, I've not had to deal with the same gravity of illness or healthcare issues. But I think we all go through life with dodging curveballs, as it were. And whether it's fear, so to speak, because of a family member. You're afraid for something for your children, or you're afraid, or if it's fear about a curveball in your career. I think the perspective that I've gained has essentially taught me to look at the horizon and look where I'm going, maybe some days more than where I am. And that's what we teach the patients, because when we teach a patient how to live with the disease, not how to die with the disease, we do a lot more. So with respect to my own, if I get caught up in the weeds with the gravity of what it is that's making me fearful, or the gravity of my worry, I often lose that perspective too. So I do think when I go to work and I'm laying out the path for somebody who's dealing with perhaps more than I am at the time, it is educational.
I love that. Yeah, this has been a really fun and rewarding conversation this evening. I'd like to ask, in closing of our podcast interview tonight, if I was to tell you that the title of Evening Rounds means to me something very special, that would be true. We spent a lot of time thinking about the title. When you think of the term Evening Rounds, what does it mean to you?
That's an interesting question. Evening rounds, oftentimes for me, is the most important part of the day. And it's different from the other kinds of rounds that we do in medicine. You know, morning rounds is all about discovery. What happened last night? What happened to the decisions you made yesterday? Who came new? What do we have to address? It's all about information gathering. Afternoon rounds, when we do them in the hospital, is about updates from the morning rounds. But evening rounds is about reflection. And it's about the time when I'm not learning anything new, but I'm thinking about what just happened. And for me, evening rounds sometimes lasts from the time I finish the last patient till the next morning. Sometimes evening rounds is going on when I'm carving wood, when I'm making bread.
Yeah.
Because there's so much information that comes to me in a day. So, I mean, there are times that I'll leave the clinic and I'll think, you know, I just spent 10 hours and somebody was talking to me constantly for 10 hours, asking me something, different people in and out, you know. I just need the quiet to reflect. That's what happens in evening rounds. And it can happen in the car when I drive home and there's no music and there's nothing but silence. I love that.
Yeah.
I love that. That's evening rounds. So evening rounds has a great significance to me, whether I've spent the day in the clinic or I've spent the day in the hospital.
Well, thank you so much again for being here. It's been a real honor.
Yeah, thank you. This has been fun. Thank you very much.
A special thanks to the sponsor of Evening Rounds, La Loma, who has provided banking services to the Loma Linda community since 1955. Their support helps us continue bringing you episodes focused on health, story, and mission.